So Jeffrey, welcome to the Therapist Hour. We're so pleased to have you here with us. And we're excited to learn more about how to work with patients who are diagnosed with personality disorders and learn about how what we know about trauma can help us with this population. So thank you.
Early in my career, I trained in behavioral therapy and different approaches of therapy, Gestalt therapy, cognitive therapy. And then I did a 2-year training program in family therapy, which was the first time that I experienced being videoed, which was pretty novel at the time. So a lot of therapists and even training programs did not videotape their sessions, especially in psychoanalytic venues. So after I worked in a psychiatric hospital, I opened my own practice, and I was a consultant in a local general hospital that had a psychiatric unit on it. And I spent about 10 hours there. I was the token psychologist. They needed a psychologist for their JCA accreditation. So I would sit in on team meetings. They wanted a multidisciplinary team. So it'd be psychiatrists, social workers, and me. And so I would sit in on all the team meetings, which I thought was fascinating. And one of the things that struck me very early is that many of the patients that were coming in who had various diagnoses at the time, and this was in the middle 80s. So this was when DSM-4 had sort of just the categorical diagnostic system had just kind of been published. And I'll talk a little bit more about that, I think, if I get time. But that kind of changed the field, because up until that time, personality disorders were not an interest of academic psychology at all. In fact, they were thought to be like kind of a soft concept that academics didn't get much into. But what happened with DSM is researchers now had a fairly reliable and valid way of diagnosing, which is needed to do research. So a number of people got into studying personality disorders. So at that time, I was in private practice, starting my practice, and I was working at this hospital. And I was noticing that many of the patients would come back time after time. So they come in for hospitalization, we'd stabilize them, they leave, they come back. And I was beginning to wonder what the heck, so we would treat their depression, their anxiety, their conduct issues, try to get a sense of what the relational issues are, which they always had. And I began to wonder if there was a better way that we could help these patients. And at that time, I was also going through a difficult time in my life, and I got into psychoanalysis. So I was going for psychoanalytic treatment for myself 3 times a week down in New Haven, Connecticut, which was one of the main bastions of psychoanalytic training. And I was thinking about, at that time, whether psychoanalytic training would give me some of the theory and tools I needed to better help characterologically disturbed patients. So there's a lot of overlap between what psychoanalytic writers who have done most of the work on personality disorders early on, and we used to call them characterological disorders. And now they're pretty much subsumed under personality disorders. So I actually had the application for psychoanalytic training in my briefcase, and I was getting prepared, was ready to fill it out. And in psychoanalytic treatment, working my practice, working in this hospital. And one of my friends, Vince Stevens, who was a brilliant psychiatrist who's no longer with us, said, before you go into psychoanalytic treatment, what I think you ought to do is go see this guy named Habib Davanloo. I don't know how many of you know about Davanloo's work, but I'm sure many of you do. So what I did at that time was I registered for one of the Cape Cod seminars where he used to go every year. I don't know how many of you are familiar with them, but there were 2 separate educational institutes that each week over the 8 weeks of the summer would have 3 different major clinicians, researchers present, and Davenlu was one of them. And so my friend said, go see Davenlu before you sign up for psychoanalytic treatment, because it's about, it's at least 7 years, and you got to continue your analytic therapy, and then you got to get analytic treatment. One of my good friends was in it, and it took him like 10 years or more. It was very expensive and time consuming. So I went to the New England Educational Institute, I believe it was, or maybe it was the other one. And I spent a week with Habib Davenlu, and I was awestruck by what I was seeing, because he was showing videotapes, which was very unusual at the time. In the, I guess that was the late 80s, that very unusual that people would show videotapes of their patients. They would get permission to show it. And so when I went to see Davenlu, and I saw the kinds of transformation that he was getting with intensive short-term dynamic therapy with some patients, I was just struck by the power of what he was doing. And I was also struck by watching the videos, how activated my own unconscious was. I was going back to my hotel room, and I was having these powerful, vivid dreams. And I decided, but at the end of the week, I went up to Davenlu, and I said, I want to go to Montreal and get into your training program. And he said, he was a little bit of a suspicious guy, and he said, well, write me a letter, and he wanted to check you out before you get accepted in the program. So I submitted the letter to get into the program in Montreal, which is a 3-year program where you have to go and present your videotapes, which was one of the best learning experiences I've had. And I think the day after that, Monday, my analytic therapy session, I went into my analyst and I said, I'm ending my analytic treatment, and I'm going off to Montreal to study with this guy. And he's like he was pretty good about it. So I ended it that day, and I never filled out my analytic training application, and I went to Montreal, and I studied with Davenlu for 3 years, and I did hundreds of videotapes of my own patients, and we would get together and study them. I had a group of peers, a color group, and we would get together and we'd look at videotapes. And I practiced that for pretty in the sort of the standard way with a number of patients for many years, and I saw the power of it. But I also started to see the kinds of iatrogenic problems that could cause. Now I'm going to get back to personality disorder, but I just want to give you like the background, because it's all about I think it's all about personality and personality disorders and dysfunction. So I saw the problems with that approach, and I actually started to circle back to my family systems training and started to reintegrate. So in a nutshell, I'd written a book in 1997 based on my work called Restructuring Personality Disorders. That was my first sort of scholarly entry into this realm, and focused on how you use brief treatment to work with patients with personality disorders. And I articulated a number of steps that you can incorporate into your training. But over the years, I've evolved. Certainly, the field has evolved in terms of the treatment of personality disorders, and so I'm going to talk about that today. So, just to add up my own personal journey and experience. So, while I was after I had finished my training in ISTDP, intensive short-term dynamic therapy, I also went through that therapy myself with one of the supposedly best short-term dynamic therapists that came out of Davenlu training, and that was I'm blocking on his name right now. He'll come back to me. So I went to New York and did block therapy, which was usually 6 sessions in one day, and then I would go back for the next day to do 4 more. So that was called intensive block therapy. Manuel Trujillo was the psychiatrist that I saw in New York. So, and I found that extremely valuable and helpful. Now, I also found my psychoanalytic treatment was very helpful too. I think each treatment I had seemed to address certain issues I had in that developmental phase. And so that's one thing I want to talk about when we talk about treating personality disorders, that I think treating personality disorders, you need to be very developmental and phase oriented. It's not a one size fits all. So I went through the short term, I think I did 80 sessions of brief treatment, block treatment, and I found that very helpful. I think it changed my life in many ways. And I think it changed my personality in some positive ways. And then later on, I actually, just to finish this up, I was at a conference with standing next to Francine Shapiro, and I was asking her, this was fairly early on in the development of EMDR, and I was asking her how it was going. And she says, oh, it's going great. And she said, oh, Jeff, do you want to get trained in it? I'll pay for your training. I said, oh, wow, that'd be nice. So she sent me I don't know how many of you are trained in EMDR, but it's pretty expensive, and it's pretty like all good training. It's time consuming. You have to take time off from your practice, and you got to pay a lot of money and try. So she sent me this coupon, and it's at my desk for years. And over the years, people would come in and say to me, do you do EMDR? I said, no, but I have someone else that does it. So I'd send them off, and then they come back sometimes and say, oh my God, this really helped me. And so I was like, what? It sounded so weird to me. You wave your fingers in front of someone's eyes and they get better. I'm much a cynic, which I think we should be as scientists, practitioners. But after a while, I thought, let me look at that coupon in my desk. And I opened my desk up, and the coupon had expired. So I emailed Francine, and she sent me another one. And I went through the training, and I went through that therapy myself as well, because I like to try the therapies that I practice. I think it's very important for us all to have experienced the therapies that we practice. So I did EMDR. I got certified in EMDR. I've been doing it for about, I would say, at least 10 years now. And I weave these all into my treatment of personality disorders. When we talk about personality disorders, we're talking about maladaptive patterns of behavior, ways of perceiving ourselves, others, ways of thinking about ourselves and others, and affect processing. And I think a lot of you are probably trained in affect phobia therapy. So one of the transdiagnostic processes that we all deal with is affect regulation and processing. I was just on a committee with APA about whether that's where we should be moving in our field, and I think that's probably where we should be moving. So personality disorders, we used to think were fixed and immutable. We know now that they're not. We also, since now I'll circle back to the DSM in the early 80s. So DSM spawned a growth in research in personality disorders. So once we had some diagnostic criteria that was fairly reliable and valid, the categorical system that you probably all know about from DSM and ICD, it's called a categorical system because what you're doing, you're checking off whether people exhibit some observable characteristics that indicate personality disorders. There's 10 personality disorders. I'm sure most of you know that. There are 3 clusters that were originally in DSM. They've gotten rid of those now, but there was cluster C, which was the dependent, avoidant, and obsessive compulsive, and passive aggressive, which they got rid of, which I thought they shouldn't, because I don't think just because they got rid of the term doesn't mean we still don't have people with passive aggressive personality. So the cluster C personality disorders are generally considered the more treatment responsive ones. And I would say that cluster C are the ones that are most responsive to briefer treatments. They're also much more responsive to affect arousing approaches, like you all have learned if you've trained in AFT. They're more responsive to those, because generally the cluster C patients generally are more repressive in what they're doing with their unconscious process and their affect. So with those patients, what we're generally doing is trying to use techniques and strategies that are going to increase emotional experiencing. And you guys know a lot of those good ones. Kristen's actually going to give us a list for our lab group to put into our compendium that we're working on of techniques. So there are a number of wonderful affect arousing techniques that we could talk about with the cluster C patients. They're generally more treatment responsive, generally do not have the level of trauma that we see in the cluster B and cluster C. So I want to talk about trauma and personality disorders and how I came upon what I believe now to be the case. So let me just finish up the DSM cluster. So there's cluster B, which is the borderline, antisocial, histrionic, and narcissistic. And then there's the cluster A, which are the more severe, the schizoid, schizotypal, and paranoid personalities. So basically, if you kind of think about them from a like a genetic neurobiological sort of framework, the cluster A tend to have the most loading coming from families with more likely to have schizoaffective disorders and schizophrenia and more severe affective disorders. So there's more of a biological loading on the cluster A disorders. So basically, when we think about treatment, we're going to think about different ways that we treat them from the cluster C or even the cluster B. Cluster C, they're going to be the patients that have the less intense trauma histories. So you think about cluster C patients, they're generally patients that have had one or more positive attachments. They may have had a loss, maybe one of their attachment figures died, maybe there was divorce, maybe one of their attachment figures had a personality disorder. There is a multi-generational transmission process. If you're interested in family treatment, I wrote a book in, I think, 2004 called Relational Therapy for Personality Disorders, which talks about the multi-generational transmission process. Also, Pressman and Pressman, The Narcissistic Family is another good family book. And then there's another book by McFarlane on family treatment of personality disorders. But getting back to the trauma, so when you think about trauma, what I've come to learn over the years in terms from my clinical work and from my scholarly work is that I would say just about everyone that I've ever treated that I would give a designation of personality disorder, when I look at their history, have had some kind of unprocessed trauma, and often extensive unprocessed trauma that has not been recognized by mental health professionals and certainly is overlooked by medical professionals. That's been a real problem. And I think we are still way behind the 8 ball on informing people about trauma-informed therapy. If you're not too familiar with it, I would highly recommend Bessel van der Kolk's book, The Body Keeps the Score, that I'm sure most of you know about. I think he thinks along the same, or I think along the same lines as he does in terms of how people have traumatic events in their life that are not addressed, leading to limbic system dysregulation, leading to developmental fixations or developmental, I call jug handles. They actually miss developmental phases. They might jump in later in life. So I want you to keep in mind, I think when you're thinking about all your patients, I want you to think about how many of your patients that you would say probably have a personality disorder, which is just a repetitive maladaptive pattern, self-sabotage and self-defeat that has many characteristics, avoidant, obsessive styles or flavors, but they generally have the same sort of driving force, that there are people that do the same thing over and over again and don't learn from it. So if you think about them and you think about if you've done a trauma history and then what the trauma has and where in their developmental phase they've had it, you can begin to kind of then get a very good understanding of what they encoded at that point in their development. Because we encode different beliefs about ourselves based on the developmental phase that we've experienced trauma. So when you're 3 and you have trauma, the kind of encodings that you get is I'm good or bad, weak or strong. Later on in life, they're more nuanced, it may be not good enough. So it's very important to think about the kind of encodings that people have based on the time frame in their development in which they've experienced trauma. Very important. So why do I think trauma is the pathway to personality disorders? Because I think what trauma does, and every patient that we work with is unique in this regard. Trauma can disrupt the developmental pathway. If we're fortunate enough to have a traumatic experience and we have 1 or 2 good attachments that can help us mitigate, process the trauma, and if we have some resiliency features, which are intelligence and support systems, then we can get back on track. If, however, you have patients who have parents who have their own self disorders or personality disorders and cannot help them, or they don't have any aunts and uncles or grandparents that can help them, they can get stuck in unprocessed trauma that puts them in high sympathetic nervous system arousal, which either winds up showing up later as people who are highly activated, sort of the cluster B patients, the borderlines and the narcissistics and the histrionics, highly reactive, or shut down, kind of like the cluster C. So what can happen is people can start to put vagal brake on their sympathetic nervous system reactions and then become more numb, shut down, and parasympathetic, sleeping a lot, having all kinds of medical issues that we see pretty commonly, fibromyalgia, chronic fatigue syndrome, all about the load that kind of sympathetic arousal places on people's nervous systems over time. I talk about to my patients, it's like driving your car with the brakes on. In terms of the current treatments, at this point, the good news is that we have at least 3, if not 5, pretty solid evidence-based treatments for personality disorders, which is quite moralizing for us. So we have dialectic behavior therapy, we have mentalization based therapy, and we have cognitive therapy that all have a pretty robust evidence base. We also have cognitive analytic therapy, which has some evidence base, and we have CBT, cognitive behavior therapy, and the Foya's work on exposure therapy. That is, although it's for trauma, I think it's been applied and blended with personality disorder treatment. So more and more people are blending the treatments to augment them. So we have a number of evidence-based therapies that I think are useful, very useful to learn. And there's also transference-focused therapy. I forgot that one, which was developed by Kernberg, Clarkin, and Yeamans, and they have a training program now in New York. The thing about the evidence-based therapies that I think is very interesting is that they all have been developed for borderline personality disorder. So when it comes to the other 9 or 10 personality disorders that we commonly see in our clinical work, there are no evidence-based treatments for narcissistic personality disorders. How many of you get narcissistic people in your practice? I get a lot of them. I work with a lot of physicians, surgeons, attorneys, and sometimes CEOs. Tends to be high on the narcissistic scale. No therapeutic approaches have been researched and has shown evidence for those. Transference-focused therapy, mentalization-based therapy, cognitive therapy, and Jeffrey Young's schema therapy is one of them, and cognitive behavioral therapy and cognitive analytic therapy are probably the most documented. Also, short-term dynamic therapy has been documented for cluster C patients. So that's probably the only treatment approach. So when I talked about getting trained in short-term dynamic therapy, that's probably the only treatment approach that has a fairly robust evidence base for treating the cluster C disorders, and I think is very good. So I think if you're trained in affect phobia therapy, you probably can do a pretty good job with the cluster C disorders. So where do we go from there? So we have this evidence base. Treatment should be based on a solid evidence base, should be based on the other two prongs of the stool are patient characteristics and values. The best treatment applied to the wrong person is going to not be effective. So if I'm a CBT person and I'm giving a lot of homework to people and they're not doing it, or they don't really respond to the model, then you can keep using a hammer for a nail. You're going to get the same results, not a very good one. So I think one of the things that we have to keep in mind when we work with this more complex group of patients who have numerous comorbid disorders, as you know, anxiety, depression, relational disturbances. They often are diagnosed with multiple personality disorders because the diagnostic system has a lot of overlap. So we have the best evidence, which I briefly reviewed with you. We have patient values and characteristics. What do they want? What fits their cultural norms and beliefs? And then clinical expertise. Now, this is the part that's been under-researched, but we know that the top 10 to 15% of therapists, if you look at Michael Lampert's work, the top 10 to 15% are the super shrinks, and they get better outcomes and more quickly than the rest. The lower 15% are people, therapists who it takes much longer to get a good outcome if they get it, and actually often do harm to patients. And what's very interesting is they're the least likely to accept feedback given to them about their work. The data must be wrong if they're telling me I'm not doing a good job. So they don't take feedback. They're the people that we need to get out of the field. But we have to learn from the top 15%. And so that's the clinical expertise. So there's no research that tells us how do you decide what approach to use at what time with what patient, and then how you might augment that. Because we know that some of the treatments stand alone do not get great results, but if you combine them, there's some evidence that's showing that if you combine them with, say, trauma-informed work, you get better outcome with some of the patients we're working with. So combining treatment is probably what we all do. We probably all have a number of different theoretical models and frameworks that we use, and we draw from them and we blend them. Where I am now in my own development and in my scholarly and research work is working on a unified model. So all the approaches have something to offer, but what are the unifying processes that kind of tie them all together? And that's where I think in the future we're going to get into transdiagnostic processes and picking from different approaches, different strategies and techniques that work within a certain framework.
Something that really stands out for me is that the more that we can learn about trauma and working with trauma, and I was really loving the fact that you've gone into your own treatment in order to understand how to treat others. It sounds like understanding ourselves, understanding trauma, understanding like what works is a wonderful way to begin to figure out how to work with our patients who have personality disorders. And the fact that you were able to identify the differences between cluster C, cluster B, and cluster A was really helpful.
You get a lot of patients, and I get a lot of patients who maybe don't reach full criteria. But if you think about personalities being a system, and let's say COVID comes along and puts allostatic loading on the whole world, families, social systems, work, that allostatic loading is going to create a stress diathesis in all of us, which is the vulnerable point. And if the vulnerable point is your personality immune system, the adaptive patterns that you developed over the years, if that gets too stressed and starts to break out, you can go from not having a personality disorder diagnosis to having one. So I want you to just keep in mind that these are not fixed or stagnant. If you put me in prison, I guarantee you would probably be diagnosing me with an antisocial personality disorder within the first couple of weeks, because that's where I'd be going to survive. So we want to think about them culturally and in terms of survival adaptations, because they're all about survival adaptations. And I'll stop there and open it up.
Jeffrey, I think that's so important what you just mentioned, because I think all of us during this pandemic times have to be aware that, for ourselves and the people that we work, we're under such stress that we are going to be able to see like what are the weaker points within our immune system. And in this case, it's personality that you're talking about. So thank you for mentioning that. Does anyone have a question or a comment just to get things rolling here? Steve Sandler, you look like you do.
I'm chafing at the bit here. Nice to see everybody. Jeffrey, great to hear your thinking again. You said we should think about the age at which the trauma occurred. I've had patients, as we all have, were traumatized from early childhood till they escaped the house at 17 or 18. Do you think about them in terms of early? Or is there another category, or do you use?
Well, I mean, I think you think about them as early, but also chronic, right?
Yeah.
So I would predict that they're the kind of patients that are going to come in that you're going to say borderline personality structure. And we didn't get time to talk about what I think is a more nuanced and sophisticated system than the psychodynamic structural system, but that's for another time. But I would say that that's more likely going to create more borderline kinds of structural problems, as you know, because most human beings are resilient. But if you put any of us in chronic situations of stress without any ability to find a mitigating attachment, it's going to stress our and disorganize our personality system. So we go back. I mean, I go back really thinking about this to the actual attachment that starts before conception, because I think even the way that your caregivers, your attachment figures have thought of you before you were conceived begins to set the stage for your personality. It's not just a genetic, your temperament, but once your temperament is formed to some degree by the stew of neuronal and stress hormones that the maternal figure is giving off. So if you have a maternal figure who's getting beaten up and abused or raped or a prostitute, and that neonate is in a soup of adrenaline and cortisol and stress hormones, that's going to affect the neurobiological system. So we got genes, and so the trauma, I think about the trauma is starting when you were thought about, like if it's, when your parents start to think about you, and then it goes on.
That's a great thought. Right. Now you're going to leave me spending the rest of the day thinking about what I thought about my son before he was born.
Yeah, so I know we should think about that, because I think about my own projections on my own kids before they, and it's interesting. It's fascinating.
It is. Thank you.
I have a question, if I could ask it.
Yes, of course, please.
Thank you so much. That was so interesting, and it's 9 o'clock here or 10 o'clock now on the West Coast, but just a great way to start the week. I was really interested in what you talked about Davin Lou and ISTDP, I'm beginning training myself, and you said you came up upon the limitations. And I was interested if you would just speak briefly about that and whether those limitations referred to personality disorders.
Well, in my humble experience, and Davin was truly a genius in many ways in terms of his psychology, in terms of some of the work he did. So I have found that my classic ISTDP, the challenging of defenses, confrontation of defenses, head-on collisions, and so forth, has benefited the patients of mine who I would say have more egocentric character pathology. So the ones that are tend to externalize, tend to blame everyone else for their problems, tend to not feel much anxiety in their own psychic emotional system. In my experience, they have been the most treatment responsive to that kind of therapy. And when I went back and did research when I was writing my first book, I found that Wilhelm Reich had actually pioneered a lot of those techniques early on. Unfortunately, we don't have any videotapes of his work, so we don't know exactly what he did, but it sounds like Davin was very much along the lines of Reich in his work. I don't think you need, for most of the patients I work with, I find that using an approach like weaving in an approach like EMDR can get me there way faster without as much iatrogenic disturbance, which is always a problem in my mind when I'm doing ISTDP, that sometimes you can cause iatrogenic disturbances. It's happened with me, and it's happened with people I've supervised using that approach. So that's my take on. I'm sure Steve has other, has something else to add probably, or may has a different opinion, but I hope I answered that, Max.
Thanks, that was great. I really appreciate it.
Well, it's just a reminder, Jeffrey, that for those of us who use Malin's two triangles in our work, if you know where a patient is on the pole, you can decide what intervention are you going to use. And sometimes it might be EMDR, sometimes it might be CBT. I mean, that's what's so beautiful about this integrated model that most of us use.
I had a question.
Yes.
I'm very interested in the part you talked about. Hi, Kristen. With values and maybe culture and or different alignments being the third arm of efficacy. And I was wondering, when they researched that, what types of ways did they measure that? Or how did you look at that?
That's a good question. You know what?
Is it just because I agree with your approach or not?
No. You know what? I am not. This is not one of my areas of expertise. There's many lines of empirical investigation into cultural and ethnic issues. It's just not my field. So I can't really answer that question for you.
But did you mark it because it was always listed in some of the studies that you looked at?
Well, the reason it's marked is because I've been on the American Psychological Association's evidence-based treatment advisory committee, and one of our early reports talked about the three legs of the stool of evidence-based practice are robust evidence, the best evidence you can find, clinical expertise, and cultural preferences and values. So that's where that comes from. And almost all treatment now, any kind of evidence-based treatment now in the manuals and in the research reports pays attention to that to some degree, because we know that if you don't understand the patient's values and beliefs and characteristics, you may be offering a treatment that's not appropriate, or you might have to modify it to. So
value in the sense of I value doing homework, but even value in the sense of I feel like you understand me at a deeper level.
Or I don't, or my culture doesn't value talking about your feelings. What do you do with that? You're a affect phobia therapist, and they say we don't, that's something we don't do in our culture. Help me. What do you do? If you only have that one approach, what do you do?
Yeah. I was just wondering about how it would, I hadn't thought of it that way. Well, I have, but I was wondering how it would play out in any particular approach like that is mostly like ICE-TDP, which I study, is mostly focused on the diagnostics moment to moment. Just don't know how to, I mean, I know that I might bring my own understanding.
Well, just think about the emphasis in ICB on intimacy and closeness and not looking in people's eyes. Like, you're not looking into my eyes, you're defensive, right?
Yeah.
So what if a person from an Eastern Asian background who maybe eye contact is disrespectful and you're saying, look into my eyes, you need to be cognizant of the person's cultural background, I think, is basically what it is in a nutshell. So, you're not doing harm because you're saying, you're avoiding me, you're not looking into my eyes. What are you going to do about that part of you that avoids me?
Yeah, absolutely, Jeffrey. This is a huge issue for training. It's really important for clinicians to understand like what are the cultural behaviors and cultural values. And the more you can learn, the more you can identify like, well, in Eastern Asian cultures, what does closeness look like? If it's not eye-to-eye contact, perhaps it's gift giving or it's, sharing tea in session. And so it's really an invitation for us to just learn more, explore, and get to know like what's culturally significant.
Or physical proximity, like how does that differ from culture to culture? I mean, I think the point is that we can't go into this blindly if we're working with people from different ethnic backgrounds and cultures, that we need to be informed, and that's part of our ethical code.
I was so interested when you talked about the different ages, because in Sweden, and I assume many other countries, they have put children into incubators, like right from birth, they are taking them away. And I'm just so curious about how that affects a grown-up who's been in an incubator.
Well, that's a wonderful question. One of my colleagues, Marilyn Sanders, is a neonatologist from Hartford Hospital, Connecticut Children's Medical Center, and she's coming out with a book very shortly on polyvagal theory. Stephen Porges, I'm sure you all know about Stephen Porges' polyvagal theory, but some of the initial findings about that is that that in itself is a potential trauma, because you're missing that attachment experience, which we know begins to make neuronal connections right away. And if that doesn't happen, we're getting a kindling, we're getting an effect where you're not kindling those attachments, and you can pass primary periods. There's some wonderful research from Romania on kids who are placed in orphanages, and it shows that there is an epigenetic phenomena that if intervention isn't early enough, the actual epigenetics change the gene expression, and it can get passed down on the kids afterwards. So it's fascinating stuff when you look at epigenetics and neuroscience, what's going on with this. But I'd be very concerned about that based on what I know.
And Jeffrey, I just want to mention a Norwegian colleague of ours by the name of Vidar Husby. He has video segments of his work with a young woman who was in that situation. And there's even video footage of her as an infant.
Wow.
That he has incorporated into the presentation of his treatment. So if you ever have a chance to meet him, certainly ask him about that case. And if he still has the video segments, it's certainly worth asking him to present that case. It's, a very successful case with a young woman who went through that as a child.
Mm-hmm. Yeah, this is a whole realm that we need to focus on, because the earlier we intervene, the better. And in terms of think about chronic maladaptive patterns of behavior that characterize personality dysfunction, which I like better than disorder, because we could all have our personality dysfunction. You can see that if you get in there early and you work on the early attachments, it's going to be preventative.
I just want to thank you so much for joining us today in the Therapist Hour. I actually feel really inspired for this upcoming year. Thanks so much for coming. So, bye-bye.
Go out there and cure.